So we'll go into the second half of the webinar. We've got Dr. Rachel Beekman from Yale University to share with us her experience as well as some of her work that she's done both with the IceCap trial and also with looking at ischemic hypoxic brain injury. So Dr. Beekman, it's all yours.
Thank you so much. So I'm going to expand a bit on what Dr. Schaefer just discussed and really talk about where I think we need to go as a field to really truly evaluate and understand the impact of temperature control. So one of the challenges in interpreting temperature control clinical trials is that we have not standardized the intervention, nor have we optimized the therapy. High-quality temperature control is a framework that focuses on delivery of a standardized intervention with optimized parameters. I would argue that we started backwards and that we need to take a pause, understand and define high-quality temperature control prior to determining if it's efficacious. This figure shows the many therapies that we call temperature control. Temperature control is a bundled intervention of which we need to set and define multiple parameters. The lack of a standardized and rapidly deployable intervention has resulted in variability in practice, and the use of pragmatic design clinical trials has resulted in significant confounding, limiting our ability to draw conclusions about specific treatment parameters. So let's consider a few different patients. Patient 1 presents with an initial core temperature of 37 degrees Celsius, has an endovascular catheter placed within 2 hours of hospital arrival, is treated with early neuromuscular blockade to minimize heat generation, and achieves a target temperature of 33 within 4 hours. Patient 2 presents with an initial core temperature of 37 degrees Celsius, has surface cooling placed 4 hours after hospital arrival. She has uncontrolled shivering, and although she's treated with escalated doses of sedation, that fails to resolve her shivering. She generates significant heat and does not actually achieve a target temperature until 8 hours after arrival. Patient 3 presents with an initial core temperature of 37 degrees Celsius. He has a cooling blanket started at hour 6, given a rise in his core temperature to 37.8, with a goal of normothermia. And patient 4 presents with an initial core temperature of 35 degrees Celsius. He drops his core temperature to 33 degrees Celsius just by covering him with ice packs. He does not shiver. He does not generate heat. He does not require treatment with sedation. Surface cooling is eventually started 8 hours after arrival. And when the surface cooling device is initiated, his core temperature had already achieved 32 as he overcooled with initiation of just ice packs. Despite significant differences in patient phenotype and selected treatment parameters, these patients are all treated with temperature control. Patient 1 and patient 4 are both cooled to 33 degrees Celsius and both achieve a target temperature rapidly. However, patient 1 receives high-quality temperature control, and patient 4 did not. Patient 4 achieved rapid induction due to impaired thermogenesis. And within the context of a clinical trial, both patient 1 and patient 4 will be in the moderate hypothermia arm. But regardless of their assigned group, for example, in the IceCap trial, if we look at the duration of cooling, the likelihood of achieving the primary outcome is markedly different between both of these patients. I would argue that patient 1 achieved high-quality temperature control with rapid initiation of a cooling device and aggressive treatment of shivering thermogenesis. Patient 2 has a delay to temperature control initiation, generates significant heat, resulting in a prolonged delay to achieve target temperature. And patient 4 presents with spontaneous hypothermia, rapidly achieves a target temperature of 33. However, this is not because we deployed high-quality cooling. It's because the patient has impaired thermogenesis. Using these case examples, you can see that when the time to achieve target temperature is the key metric, it's very hard to differentiate between patient 1 and patient 4. The problem is that the likelihood of benefit of the intervention may be different for each of these patients. It is really important to be able to differentiate patient-related factors from implementation-related factors. High-quality temperature control must be defined based on implementation factors, such as the time to initiate therapy or treatments for shivering thermogenesis, rather than time to achieve target temperature. In this figure, you can see temperature curves that are suboptimal, such as delayed cooling, breakthrough fever, or increased time out of temperature range. While high-quality temperature control should aim to achieve the highest percentage of time within the goal temperature range, it's not the only variable that's important. So let's look at two patients again. Patient 1 presents with a target temperature of 34 degrees Celsius, has fixed and dilated pupils and widespread brain injury on initial head CT. I think we can all agree that even if we standardize high-quality temperature control, the likelihood of benefit for this patient may be low. Patient 2 presents with a core temperature of 34 degrees Celsius. His brainstem is intact, and his head CT shows no acute pathology. While I'm not sure if high-quality temperature control will benefit this patient, the likelihood is significantly higher than patient 1. While spontaneous hypothermia may be associated with brain injury severity, other factors likely interact and modify outcomes. So let's review a real case. We have a 46-year-old man who presents with a non-shockable rhythm after drowning. The arrest is unwitnessed. He has at least 23 minutes of CPR. His post-ROSC labs are extremely concerning, as is his examination. He has brainstem areflexia with fixed and dilated pupils. He does not trigger the ventilator. He has no motor response. His core temperature on arrival is 32 degrees Celsius. If I poll this audience, I would expect that few people think this patient will have a good outcome. And that would be consistent with predictions based on illness severity scores. So for this patient, his revised post-cardiac arrest syndrome for therapeutic hypothermia, or RCAS score, is 18.5. That's the highest score that you can get. And this score was found to have a near 100% specificity for poor outcome. But does your thinking change if I tell you that he presented in winter and was swimming outdoors? Our team was initially concerned for catastrophic brain injury. However, his initial head CT was reassuring. So we kept him at a target of 33 degrees Celsius and treated him aggressively. He was initially hemodynamically unstable, but with ICU supportive care, he improved over the subsequent 48 hours. He was ultimately discharged home 2 weeks following cardiac arrest with a cerebral Pittsburgh category score of 2. He had an inpatient speech, language, and cognitive evaluation, which showed a brief cognitive assessment score of 28, consistent with moderate cognitive impairment. And that subsequently improved to normal in follow-up visits. We have all seen cases in the literature of unexpected good outcomes following hypothermic cardiac arrest. These cases and the results of preclinical studies strongly support the biologic plausibility of hypothermia as an effective treatment for hypoxic ischemic brain injury. So we then have to ask ourselves, where is the translational gap? In the optimal trial design, we need to control for patient-related factors. It's important to identify early, reliable biomarkers of brain injury severity so we can phenotype patients and assess the impact of temperature control across like groups. I believe that two major gaps are needed to be addressed before we can run successful temperature control trials. The first is defining high-quality temperature control and standardizing the intervention parameters. And the second is identifying early biomarkers that can phenotype patients based on injury severity. As we saw in the case with unexpected good outcome, illness severity scores are not perfect, but I would argue that they're probably better than treating all cases as equal likelihood for identifying a treatment effect. As you can see in this study of 118 out-of-hospital cardiac arrest patients treated with temperature control to 33 degrees Celsius, patients with poor outcome had a lower core temperature prior to initiation of temperature control and more rapidly achieved the target temperature. This study evaluated the water bath temperatures during each phase of temperature control and found that a low heat index was associated with poor neurologic outcome. Heat index is the inverse of the water bath temperature, and it evaluates if a patient is resisting cooling. Non-brain injured patients will typically generate heat when cooling is initiated as a way of maintaining homeostasis. Brain injured patients, alternatively, do not generate heat. While the pathophysiologic mechanisms for this are not yet to be proven, it's hypothesized that patients with severe hypoxic ischemic brain injury on presentation have damage to the hypothalamus, which impacts their ability to regulate their temperature. In a study of 57 patients with continuous water bath temperatures, a higher heat index was associated with survival, favorable neurologic outcomes, and lower post-cardiac arrest syndrome severity. This study also found that heat index correlated well with the arteriovenous carbon dioxide gradient, suggesting that heat index is a measure of metabolic rate. All temperature-controlled studies going forward should collect data on heat index to understand how treatments such as neuromuscular blockade or patient-related factors such as low heat index impact the neuroprotective role of temperature control. As the optimal parameters for temperature control are unknown, there is large variability in practice. It's not only plausible, but highly likely that the neuroprotective effect of temperature control is impacted by patient-related factors, such as post-cardiac arrest syndrome severity and implementation factors. The currently enrolling IceCap trial does not stratify by illness severity, only by initial rhythm. And as seen in these figures, there's significant variability in process measures. The figure on the left shows the median time from hospital arrival to device initiation, and the figure on the right shows the proportion of subjects treated with neuromuscular blockade on day 1. At our medical center, enrollment in the IceCap trial has helped us to improve our pre-induction time. Prior to 2022, only 6% of our out-of-hospital cardiac arrest patients had temperature control initiated in the emergency department. And due to prolonged boarding times, that meant that initiation of temperature control was significantly delayed until the time that they arrived in the ICU. Between 2022 and 2024, close to 50% of our patients had temperature control initiated in the emergency department. This improvement in the quality of care allowed us to evaluate the impact of pre-induction time on outcomes in patients treated with temperature control. We defined pre-induction time as the time from hospital arrival until the time that we initiated a temperature control device with a closed loop feedback. For the overall cohort, the median time from hospital arrival to device initiation was 4.5 hours. 22% of the cohort met criteria for early device initiation, which was defined as less than 3 hours, with a median time to connection of 2.5 hours. The overall cohort differed significantly from the TTM2 cohort, and you can see that our patients had 33% shockable rhythm, only 44% received bystander CPR, and the mean lactate was 9. The median Pittsburgh cardiac arrest category score for these patients was 4. As we retrospectively evaluated that there was associations between pre-induction time and we found group differences, we tried to minimize the measurable confounding by using a sensitivity analysis, using inverse probability treatment weighting. As you can see in this table, following propensity score matching, the two cohorts were very well balanced with respect to known confounders. As you can see in this figure, 28% of the patients that were treated with early temperature control achieved good neurologic outcome, defined by a cerebral performance category score of 1 to 2, while only 15.5 of those achieved good neurologic outcome when they had late pre-induction. As you can see in this figure, early pre-induction was associated with good neurologic outcome, and it had an odds ratio of 1.95 with a confidence interval of 1.19 to 3.79. In addition, we identified that there was a linear association between the time to connect a temperature control device and the log odds of good neurologic outcome. And in fact, each hour delay in time to initiate a temperature device was associated with a 20% decrease odds of good neurologic outcome. In patients with preserved thermoregulatory responses, shivering is a natural process that occurs when exposed to hypothermia. Neuromuscular blockade can be used to inhibit shivering and increase induction speed. In a post-hoc analysis of a prospective multi-center observational cohort study, 516 patients who were treated with temperature control and had data on neuromuscular blockade use were included. As you can see in this figure, the proportion of patients who survived and achieved good neurologic outcome was higher in those who were treated with neuromuscular blockade. Furthermore, the group that was treated with neuromuscular blockade had a shorter induction time by about an hour and a half. We validated this data in our cohort and found that both the time to initiate temperature control and the use of neuromuscular blockade during induction were important process metrics. We are currently evaluating the association between high-quality temperature control and outcomes. We used a score that is based on two parameters that appear to be important: the pre-induction time, or the time it takes to initiate temperature control, and the pharmacologic management of shivering. This score ranges from 0 to 6, with 0 being the lowest quality and 6 being the highest quality. We found that the quality of temperature control has a linear relationship with outcome once you achieve a score of 3 or higher. As such, a score of 0 to 2 was considered low quality, and a score of 3 to 6 was defined as high quality. While all work is preliminary, we found that an increase in the quality score was associated with improved neurologic outcomes. In an effort to minimize measurable confounding, in this analysis, we also did inverse probability treatment weighting to make sure that the groups were balanced. As you can see in this figure, patients treated with low quality temperature control had a survival rate of 18.6, compared to almost 40% in those that were treated with high quality temperature control. Likewise, good neurologic outcomes, again defined as a cerebral performance category score of 1 to 2, occurred in 11.5% of the patients treated with low quality temperature control, but occurred in 26.2% of those who were treated with high quality temperature control. This data suggests that process metrics are important and may actually impact the neuroprotective effect of temperature control. I also want to highlight the differences between hypothermia, normothermia, and fever prevention, which all fall under the term of temperature control. In hypothermia, the target temperature ranges from 33 to 36 degrees Celsius, followed by slow and controlled rewarming, with an additional duration of fever prevention, typically providing 72 hours of therapy. Normothermia refers to targeting temperature of less than or equal to 37.5 degrees Celsius, using preventative measures such as Tylenol, ice packs, with escalation to device-related control if the temperature hits 37.8. Fever prevention is similar to normothermia, but is typically the term used when we're referring to the time period after the initial 24 hours of therapy. It's very important to recognize that close to 50% of the TTM2 cohort used a device to maintain normothermia, and a truly reactive approach to fever is not considered temperature control. Following acute brain injury, we know that fever results in endothelial damage, blood-brain barrier disruption, increased cerebral metabolism, glutamate release, and inflammation, all of which increase the risk for secondary brain injury. As you can see in these figures, which are specific to the cardiac arrest population, both the severity of fever and the duration of fever are associated with worse outcomes. In this systematic review and meta-analysis of 15 randomized controlled trials involving over 5,000 patients with cardiac arrest, you can see that any temperature control method, inclusive of strict normothermia or fever prevention, were superior to no temperature control. It is critical that when we talk about temperature control in a TTM2 trial, that we do not mistake normothermia or fever prevention for a reactive approach to fever, which is not considered temperature control and is known to be harmful. As a community, one of the important research priorities should be defining and standardizing high-quality temperature control. This will require identification of the therapeutic window and evaluating which parameters are the most crucial. We also need to optimize our initial treatment approaches. Following the lead from the cardiovascular and stroke world, we need to focus on policies and procedures that improve door-to-temperature control time, while still optimizing brain-centered resuscitation and triaging the acute needs of this incredibly sick population. Our hospital, like many others, uses a chill alert with the goal of optimizing early management and getting emergency physicians, neurocritical care, and cardiology experts to the bedside immediately for a team-based approach. I also think we need to start smaller and focus on centers that are capable of providing high-quality temperature control to first evaluate if by focusing on implementation, we can explain the translational gap prior to proceeding with larger trials focused on generalizability. In summary, there is a strong biologic plausibility that hypothermia is a neuroprotective treatment. The translational gap is at least in part due to pragmatic trial design and the absence of a well-defined and standardized, easily deployable intervention. Our priorities need to be defining high-quality temperature control, exploring methods to achieve high-quality temperature control, and identifying early biomarkers to help phenotype our patients and refine clinical trial selection criteria. We should be starting small with proof of concept and then expanding to generalize our findings. Temperature control is still recommended for all unresponsive cardiac arrest patients, and a reactive approach to fever is not considered temperature control. And I'm going to pause there and I will take any questions.
Okay, thank you very much, Dr. Beekman. So we will open it up for questions.